So there is a general philosophy in science that it's better to have more information. So I wonder, do you agree that it's better to always have more information, or sometimes is it better to have less information? So by show of hands, who thinks it's better to have more information? Who thinks sometimes it's better to have less information? Yeah, very brave, I agree with you. So the people with their hands up now, why would it be better to have less information? Anybody?
Because
Yeah.
I've been...
Go. Go to the audience. You don't need to know too much, you could have overload. Was this the same response, or?
Yeah, because with too much information, you have to find a way to combine them.
Okay, there's two. Another one would be, is it good information? We're assuming it's good or perfect. So sometimes, even if information is perfect, we might not want it. Imagine I could tell you the date you will die. Hands up if you want me to tell you. It's perfect information, no? Most people don't want to know, and it's perfect. So keep this in mind. We're going to be talking about continuous glucose monitors. They're just something that provides information, and we want to decide if we want it. In case you haven't heard of them, these are continuous glucose monitors, typically worn on the back of the arm or on the tummy. They can be worn in other places. And they've been around for about 20 years now. They used to work for about 3 days. Now you can get a couple of weeks of continuous glucose measurements from these. And we're ultimately going to be asking today whether these give good information and useful information. I have experience using a number of these, most of the ones on this side closer to me. By way of a disclosure of interest, I have done consultancy for companies trying to work out how to make this information useful. I've used a number of these in published studies funded by the sugar industry, so it's important I tell you that. And as you heard, I'm editor-in-chief of the International Journal of Sport Nutrition and Exercise Metabolism. So those could all be sources of bias you should also know about. So as I said, we're going to ask first, do they give accurate and ideally precise information? So that's really talking about reliability and validity. And then the second part of the talk, we'll look at the good, the bad, and the ugly. What can we say with this data? What shouldn't we say that's bad, people do say? And then for the ugly, I'll look at what might we be able to say in the future. So just in case you are not familiar with continuous glucose monitors, we need to understand what they actually are. And you would be forgiven for thinking they are monitors that measure your glucose in the blood continuously. That seems a fair thing to assume. Let's interrogate that. Are they continuous? Well, you can see some data here. This is glucose concentrations across a 24-hour period from a study we did about breakfast versus fasting. That doesn't really matter about breakfast today. You can see this high frequency, high resolution of measurement. So they're kind of continuous. They're not quite real time. There's some delay with the processing time, and different companies won't tell you the data right away. And there's also a physiological delay that I'll come to. And this also links, I would say this is a strength though. It is more or less continuous. That frequency, the resolution, and the duration of monitoring, especially now it's a couple of weeks, I do think has some value in it. But that depends how we express it. So many people use this tool and then just report an average value for 24 hours. Well, if we're interested in average, just take 4 finger pricks during the day, and the mean will probably be the same as your continuous glucose monitor. And you can calibrate some of these. That's an important thing to note now. You can take finger pricks to calibrate the values to blood. Which links to my next point. They measure the blood, don't they? Nope. This is how they're worn. You have a small filament that goes down into the interstitial fluid. So they're not measuring the blood. We're hoping that the glucose that is in the blood at the bottom will travel through into the interstitial fluid, and we measure it there. So this is another part where that delay can come in. In certain conditions, there can be a longer delay. It's certainly 5 or 10 minutes between the value in the blood and what you see in the interstitial fluid, and some situations we'll come to, like exercise, that can be worse. What was the other thing I was going to say about this one? As well as there being a delay here, that's why the calibration is important. So you might say, when people call this blood glucose, some of us can seem very clever and say, it's not blood glucose, it's interstitial glucose. I actually think it's measuring interstitial glucose, but it is correct for you to call the result blood glucose. Because when it's calibrated especially, the algorithm is converting what it sees in the interstitial fluid and applying an adjustment to try and say what is blood. So it's giving you a blood result, even though the measurement it made wasn't in the blood. So it must be true that it's measuring glucose, surely. No. So if you can't tell the difference, neither can your continuous glucose monitor. That's glucose on the left and ascorbic acid, vitamin C, on the right. So there's a number of things in the diet that can interfere with this. Vitamin C is detected by some monitors as glucose. Ketones, if you're fasting and your blood ketones come up, can interfere, and some medicines can interfere. A current PhD student of mine, Katie Hutchins, did this study just this year, which I think is so important. Innocent smoothies were getting fed up with the fact that everybody was demonizing smoothies and saying, well, my CGM says that it causes huge glucose spikes. So we had people do this comprehensive study where they have the smoothies, we put an intravenous catheter in, and we can measure blood glucose and compare with the CGM. The CGM overestimates, and we think part of that is that it sees the vitamin C, which is probably something you want in your diet, but it's blaming that as a glucose curve. So it's not always measuring glucose either. And then it's monitoring, at least it's measuring something. Well, there's one thing that people rarely talk about is that a lot of the software will use something called back smoothing. I noticed this as soon as I used them. I would eat something and see a glucose value of 12 millimole per litre, and I'd be very worried about that. And then when I look back later in the day to show somebody I had that score, it's not there anymore. Because the software, if it sees these high peaks, random high values, it can take those out to smooth things off, which in some ways I agree with. My catchphrase here is you should be analysing patterns, not peaks. But as a scientist, I'm very wary of cherry picking and taking out those extremes. And this is relevant for athletes. If they want to use it real time to take action now, we need to know that the score they see now isn't going to be deleted later from their 24-hour value. And then I found this very amusing. When I was looking for recent developments in the continuous glucose monitor world, some manufacturers of continuous glucose monitors have decided that their next marketing strategy is to tell you don't need a continuous glucose monitor. They can do deviceless forecasting. So the catchphrase I've seen is they can predict spikes before they happen. So the way I think that works, I've drawn up a phone here for how it would look, is you tell the software you're about to eat a big piece of cake, and it uses a clever algorithm to tell you that your blood sugar is probably going to increase a little. So I'm being facetious there with this silly example, but not really, because their response to that, I'm sure, would be, no, we're thinking of more modest foods if you're saying I'm going to have pasta versus a sandwich. So put a star in that. We're going to come back to that idea when I show you some data in a moment. So we've found that continuous glucose monitors are not always monitoring. Sometimes they're just using values that have been guesstimated. It's not glucose always, it's not the blood, and it's kind of continuous. And then our final focus for today is we're trying to focus on female athletes. So I would point you towards this excellent review from Heliput just a few months ago, where I think I would agree with their overall conclusions, which would mirror the conclusions of this talk, is for diabetes, these things are an absolute blessing. They're wonderful to be able to take action in diabetes and monitor health. When we move along to a healthy or at least non-diabetic population, much less valuable. And our question today is, what about athletes and what about female athletes? Are there going to be additional problems or are there additional opportunities? So like I said, we've established what they are. We're going to look at the validity and reliability of these monitors. And then we're going to go through the good, bad, and ugly. How can we use them? How can't we use them? And how might we use them? So in terms of reliability and validity, I've got a couple of studies to show here. This one from Freckman is relatively recent, and it's looking here at the MARD on the axis is the mean absolute relative difference. So it's truly looking at internal validity. They're comparing the number of measurements that have been made with a CGM with the true score, and you can see that back when these things were launched around the year 2000, there's a wide range, and it's up at around 20%, so they're out by about 20%. And the good news is scientific progress means we've been bringing that down and down and down. By the end there, it's about 12% variability. Since this review in 2023, I think I've seen a number of studies down at 10% or even slightly less. So let's accept that today maybe we have a 10% error in these studies, and that I envisage that might get a little better. There's some inherent problems that will always result in some variability, but this links back to what I just said about how it could be useful for diabetes but not for healthy individuals. If your child has type 1 diabetes, if a family member has type 2 diabetes, and you get a notification on your phone to tell you that their glucose is 20 millimole per litre, that's not good news. You don't care about 10% error. It could be 18, it could be 22, but your action would be the same. So that's useful information. The problem is now the public are using it to check what their fasted glucose is. So it's telling you your fasted glucose is 5.5. Could be 6, could be 5. To be honest with you, if you woke up in the morning, I could just guess your glucose was probably 5.5. So it's not a lot better than guessing for those fasted values. And strangely, the conclusion across this literature seems to be that while there's an improving and maybe acceptable for diabetes prediction with fasted basal values, where these monitors struggle is any time there is a change in glucose. And that just really confuses me. We've developed a monitor to measure your responses, and the conclusion is that they're not so good if there is a response. So anything that changes your glucose, feeding, exercise, if you exercise hard, you can get most healthy people can get their glucose far higher from exercise when adrenaline stimulates the liver to kick out some of your endogenous sugar. So those situations, they're not going to perform so well. So rate of change, particularly high values, they're not great with. And we do know that a big area where there needs to be improvement is hypoglycemia. Low blood glucose is not something that they cope particularly well with. And a lot of these monitors, I'll mention later, but especially if you're asleep or leaning on them, they'll just give physiologically impossibly low values, often down below 2 millimole per litre for hours at a time. And that's not real. And I think, as we'll come to, one of the things I think athletes would be interested more in is hypoglycemia, but yet that's not an area where they're particularly good. So I've mentioned that meal responses is one of the areas where these monitors can struggle and have difficulty. The data shown here was a nice study, again, just done this year. I've tried to give you the most up-to-date literature by Aaron Hengist, who was with our group up until recently. It's very rare that you see a study where 2 different manufacturers' continuous glucose monitors have been used. This is using the Abbott monitor and the Dexcom monitor. Dexcom is the purple and Abbott is in green. You're seeing a Bland-Altman plot here, essentially the agreement between the response to the same meal twice. So if you did this study, you would wear an Abbott monitor on one arm, a Dexcom monitor on the other arm, and have a given meal, and then come back 1 week later and have the exact same meal, having prepared in the same way. And the agreement is highly variable for both monitors. So the agreement between those meals, the correlation, was weak to modest at best. And in fact, they word it very nicely in the discussion to say the agreement between those 2 identical meals is about the same as if you compare that meal to any other different meal. So think back to what I said about this new software that says it's going to forecast your response. And I said, well, it will know a cake gives you a sugar response. That's probably about as good as it gets. If you've got 2 just normal type of meals, there's very little predictive validity in being able to know what happens with those. Interestingly, as a rare example of a study where they have included 2 different monitors, they did do the correlation between the two, and that's not great either. You get a correlation that's maybe just above moderate for the agreement between two different brands. So it really is important that you compare the same type of sensors with one another. Part of that may be, as I mentioned earlier, when some monitors struggle with vitamin C and others struggle to detect through ketones, there's different challenges for the different manufacturers. The good news from this, though, was if you wore two of the same sensor on your body, so if you wore one by the same manufacturer on both arms, that gave excellent agreement. So the different positions on the body for the same monitor would be okay. So that shows how the meal response causes these monitors to struggle a little. The other thing that's relevant today that can cause a rapid change in blood sugars and may cause an issue with the prediction is exercise. So this study over here, again, just from last year, they had, these were Paralympic athletes either doing arm exercise during weeks and weeks of training or doing leg exercise. And you can see here that at rest, you've got that reasonable predictive ability. So this is the plus 0.2 in green on the left is showing that at rest, the systematic bias between a capillary sample of actual blood and the continuous glucose monitor sample is relatively close. That systematic bias is 7 or 8 times greater as soon as you have people exercise. So when they were exercising here, you get a greater bias. The continuous glucose monitors are not so good at predicting. Part of that is going to be that delay I mentioned. There's a 5 to 10 minute delay between what happens in the blood and what happens in the interstitial fluid. And if you exercise, there's changes in flux and the tissue uptake of the glucose, so that delay can be greater and last for longer. This is partly, therefore, linked to intensity. So if you are working with athletes, the higher the intensity, arguably the worse that situation could be. So what we have established then is that we've established the baseline at the top of the things that these monitors can and can't do, and we understand why. We can see on the left-hand side of the screen that the prediction is getting better, but I would argue is probably still too far out to be useful for healthy people, that meal responses don't show good agreement, and that exercise can cause poor agreement, all situations when athletes might be interested. So we move on to the good, the bad, and the ugly. As I said, what we should and can use continuous glucose measurements for, that useful application of the information. The bad, what we shouldn't use it for, and sadly, I see lots of people making suggestions about how we can use these monitors. This is fairly standard practice in the kind of field of wearable technologies. We find that a wearable will generally measure one thing, and that's what it's designed to do, and then to sell them, the manufacturers have to add on other things. A good example would be, many of you will have a smartwatch on. I've got yours here, sorry. But it will tell you the time. They're good at telling you the time, watches, and it can often measure your heart rate, for example. But then there'll be other things packaged in. It will tell you blood pressure. It will tell you your sleep quality. And these are not really things that it can do. And the same is true of glucose monitors. I'll cover what they can do and what people think they can do, but they probably can't. And instead of the ugly, I'll change that to the maybe. These are the areas where there's some potential for using a glucose monitor for this information, and potentially areas where I think there's an opportunity to make better use of them. So hopefully you'll come away today with the idea that I'm neither pro or against these things. I just think we need to be aware of what information is useful. Okay, so on to the good. It can measure glucose. That's probably no surprise to you. So let's just look at the actual metrics, the numbers it gives. We've said already that they might not be accurate or precise, or there's some questions over reliability and validity. But even if we assume that that's perfect, and it's a perfect measurement, how may we use it? So it can tell us absolute concentrations. It will give you a value, and they could be fasted values, intermeal values, or a common thing, a threshold to apply in the general population is what is the value exactly 2 hours after a meal? And these are the kind of numbers that you might work with the general population. We would hope that fasted values are between 3.9 and 5.5. I'm not really going into how the elevated levels there that you might see for diabetes here. These are all thresholds taken from the World Health Organization, the National Institute for Clinical Excellence, and the International Diabetes Federation. So very well established ranges. The intermeal interval means not overnight fasted, but what your sugars were like before we went for lunch. So when you're ready for your next meal in the day. So you haven't eaten for 2 to 3 hours, say. You are not quite post-absorptive, but maybe fasted. We'd hope that that is still below 6. And then the 2-hour post-meal threshold is you really want for a healthy person to see your blood sugar back down below 7.8 millimole per litre. If it's between 7.8 and 11.1, you might be thinking of prediabetes. This person is struggling to clear the glucose from the circulation, and above 11.1, then you'd be exploring diabetic possibilities. Beyond the absolute concentrations then, we can get those from a single blood sample. So that's not so fascinating. We can get 24-hour diurnal and nocturnal values. So in terms of these averages, I've taken these again from World Health Organization, and a couple of nice studies in this area was the Frankman one I showed you from 2007, and there's a more recent one from 2019 by Shah, S-H-A-H, where generally you'd be looking at, in a healthy, or at least non-diabetic population, values between 5 and 5.5 would be typical. So if you're wearing one of these and you want some kind of norm reference, 5 to 5.5. Individuals above 60, it can be closer to 5.8 for your 24-hour average. Diurnal values are useful. This means from when you wake to when you go to bed, because they're telling you a combination of your metabolic control and your dietary exposure, right? There's 2 ways to get your sugar down. One is to eat less sugar, so you put less in, and one is to become healthier, so you control it better. So the diurnal value tends to be telling you about both. It might be high because you had too much sugar. It might be high because you're struggling to control the amount of sugar you had. And the nocturnal values can be really useful then, because you can see they're slightly lower, 4.5 to 5.4, because you shouldn't be eating at night time then, and we can actually see just simply what your levels of glucose are while you're asleep. That can also be useful because we know there is a diurnal rhythm in these sugar responses. When you first wake in the morning, sometimes your actual blood sugar level, your absolute level, can be elevated a bit. It's known as the dawn phenomenon. Your cortisol has come up by that point, and you can have slightly elevated blood sugar first thing in the morning, even though you didn't eat. Yet paradoxically, at that point of day is when you're probably most sensitive to the effects of insulin. Now, these are the type of values that I value a bit more, because I think we start to get more insight into the actual strength of these monitors to show us a temporal resolution of the response. Time in range, so people tend to say if that range that we want healthy people to be in is from 3.9 to 7.8, how much of your day is in that space? And for anyone under 60 years old, 96% of measurement should be within that range. You wouldn't, if there is a short spike above it, doesn't really matter, but you're really looking at the whole day then. How big are your spikes? How many of them are there? And how long does it take you to come back down again? Those 3 factors obviously are what dictate your time above the range. For individuals over 60, that's slightly lower, maybe 93%, but still the vast majority of values should be in range. The diurnal coefficient of variation, so during the day, a coefficient of variation is just the standard deviation adjusted for the mean. You should be looking at about 17%, again, in a healthy population. And the nocturnal, because there's no meals, 13%. And we've done studies where we've checked to see certain interventions can change this. But variability, I think, is an important one. It combines everything together about how many times your glucose changes and the magnitude of those glucose excursions. Okay, and then lastly, some more really useful ones, I think, are markers of response. MAGE is our mean average glucose excursion. So that is the change between your peak and your basal glucose, so how much it has changed in response to a given feeding. And the general thinking is that you don't want that to change more than 1.7 millimole per litre. And the threshold to say there may be a problem with glycemic control is 3.6 millimole per litre. So this is a good marker when we want to just focus on a particular part of the day and say we know what the person ate. Are there any meals? Are there any particular things that person does that result in a MAGE that is higher than 1.7 millimole per litre? Area under curve, I showed you some area under curve data from the Hengist study. That's a common composite measure to say how long your glucose stays up after a feeding. I can't give you an average value because it would be entirely dependent on the context of the food and the person. The ones at the bottom here that I do think there's a lot of value in is the peak, nadir or low value, and the time to peak. Often when I'm doing research studies and we're looking at the average values and the area under curve, if you're ever getting hints that a treatment is doing something, it often comes through when you start to look at peaks. And critically, I'd recommend if you want to look at peaks in your athletes or your research studies, I say we should be using individual peaks for this. So don't look at your graph and say it peaks at 1 hour, so I'll take everybody's 1 hour value. Because you have that time resolution, you can take the highest value that you got from each individual and average those together. Okay, on to the bad. Those are the things that glucose monitors directly tell us. What are the bad things that people are using these for that I really don't think there is validity to do that? Well, fueling and fatigue, two things very relevant to athletes where I don't think we can do this. People are already using these to say, well, if my glucose is low, have I not fueled appropriately? And if it's high, does that mean I've fueled appropriately? The little graph on the right reminds us that we have lots of glucose available in our bodies. You could have up to 1 kilogram, up to 1,000 grams of glucose between your muscle, your liver, your kidneys, the brain, certainly half a kilogram most of the time. You've got a couple of teaspoons full in your blood. So we're measuring this one place in the middle between our major sources of glucose. And it is very easy to uncouple the two, to have someone with high carbohydrate availability but low blood glucose, or vice versa. So a measurement of glucose in the circulation is not a good measurement of whole body even glucose availability. And that's even before we recognize the fact that athletes are not just running on glucose. They have all sorts of other fuels, from lactate, ketones, fats, of course, even branched-chain amino acids. We have lots of fuel available, so why we would take this one snapshot of glucose as it passes through the circulation and think that that's useful. So I don't think we can use it as an indication that the athlete has fueled properly. And that's really illustrated by this nice study from Hamilton et al. You have 9 days of training here. This was in elite female athletes during a 9-day training camp. They're cyclists on the world tour. And during that training camp, these are all the individual scores, really just to illustrate that almost all those scores, like I think it was 93% of the scores, are in the normal range. Even in athletes training hard, recovering hard, eating lots of carbohydrate, their scores are in the normal range for the 3.9 to 7.8. The glucose variability was in the mid-teens, as you would expect. So actually what we find is, especially for an athlete whose metabolism is optimized, they have great metabolic control, the body very nicely controls glucose homeostasis. It wants to keep your glucose in between the actual concentration in a tight range, and it can adjust the fluxes, the rates of appearance and disappearance, to achieve that quite nicely. So bottom line there is that glucose monitors aren't telling you how well you fueled or really how much you fatigued. There's a couple, I haven't shown them here, but there's a couple of other nice studies now that have shown that the levels of variability and excursions in athletes really don't predict their performance in these events either. So there's no advantage even to having slightly better glucose control. That really pertains to hypoglycemia when you get towards the fatigue. So there's not good evidence that endurance athletes are getting hypoglycemic at the end of an event, or at least they shouldn't be if they eat correctly, and that glucose monitors couldn't help with that. There is another type of hypoglycemia, though, illustrated in this study from Afman. I'm aware that most metabolism studies are cyclists or runners, so for the intermittent games players in the room, this was a basketball study where we fed people carbohydrate right before exercise, and you can see the black line on the left there. We spike their sugars, and then they crash out during the first 2 quarters. This is known as rebound hypoglycemia. When you commence exercise with elevated insulin, the insulin stimulates glucose uptake, and then the contraction does, and they're superimposed, so you kind of overshoot. You can see this crazy low glucose during the first quarter, which translates on the right to impaired performance. They were just missing layups when they shouldn't be. So I do think there's some potential that rebound hypoglycemia could affect skill performance, and maybe a glucose monitor could help you identify people who are at risk of that. Okay, on to the final part then, the maybe. Where do I think there is potential that we could use these and that could be useful for athletes? Diet, sleep, and rhythms. So I'll just talk through those 3 things now. In terms of diet, I've said it can't tell you how you've fueled, but I do believe that a continuous glucose monitor can be a good way just to check what somebody is eating and help them make sense of it. So if a person is trying to eat less carbohydrate, they can use that to see where they may have screwed up with that. If there's a food that they didn't realize was rich in sugar, the CGM will probably be good enough to tell them that that had happened. And I think they might also be useful. Many of us just would struggle to follow a diet anyway. It can be a helpful motivator to encourage you when you know that there's a glucose monitor reminding you what you're trying to do with it. The thing I would add here, though, is so many studies, so many influencers out there on YouTube will talk about how if you eat a low carbohydrate diet, you improve your metabolic control. So really what they're saying is that you can control your blood sugar by eating less sugar. And for me, that's the same as saying you can control your dog better by not owning a dog. So that's not improved metabolic control. Seriously, look on PubMed, and there's just paper after paper says this diet improved metabolic control. If it reduces carbohydrate intake, you've removed the stimulus. Improved metabolic control means same stimulus and you control it better, you tolerate that sugar better. So I don't think we can use CGMs to talk about metabolic control unless diet is standardized, which it doesn't tend to be in the real world. Sleep then. I think sleep is an important area where we have an opportunity here. If you keep waking people up in the night to take a blood sample, you can't study sleep because you've woken them up. So here we have a passive way to measure glucose, to do so continuously in this relatively non-invasive way. There's good reasons to do that. So there is a line of thinking that possibly, again, while I said that we can't test fueling with CGMs, there is some data suggesting that if athletes are really training too hard or not eating right, it may be an early warning sign if their blood sugars are a little low at night time. So that needs to be explored. But remember what I said earlier, that if you wear these at night and you lay on them, we often would get very low values. Often when we've used them on obese participants, you just get very low values anyway during the night. So I think there needs to be some technical work done to get them to work better at nighttime. But I think there is good reason to study nighttime glucose. There's reason to believe that changes in diet can affect nighttime glucose, but also that what you eat can affect your sleep quality. So another thing that I would say I see as the future here is to integrate the signals from CGMs with other wearables. So you've probably got other wearables that are telling you how your sleep was, were telling you when you were exercising. Why can't we just have one app that integrates all of that? So if your glucose shoots up, then the app can know, well, heart rate was 180 at this point. So it's probably not a meal that has done that. It's an exercise-induced response. So sleep, I think, is an important one. I don't think I mentioned earlier, there is a bit of a hardware issue that these monitors fall off quite frequently. And given that they are quite expensive still to buy, that is relevant. And if you're working with an athlete, it might be if you want to put them on for an important event, you can't do that over twice. So you might want to stick more than one on. You then get duplicate measurements as well. But they do commonly fall off, and you can't just put a bandage round to hold them on. If they're compressed against the skin, they don't work so well. And then the last thing is something that's close to my heart and linked to the sleep response is rhythms in our physiology. My main research area is this, all the wonderful cyclic patterns that we see in our physiology, whether they are over a few seconds, minutes. You're probably more familiar with the 24-hour rhythms, circadian rhythms in all sorts of measurements, and longer-term ones. These continuous glucose monitors are really made for that kind of thing. So we should really be trying to use them to understand rhythms, and again, to integrate other knowledge of time responses with the CGM. That's where we get the value from that resolution and duration that I started with. And since we're talking about female physiology, particularly in today, these monthly rhythms are really important here. We know that when all the female sex hormones are higher shortly before ovulation, that's when insulin sensitivity is better. I see no reason why a continuous glucose monitor couldn't start to take that into account. And instead of saying, well, during the early phases of the cycle, if it says you're getting high glucose readings, what are you eating? It could just be that insulin sensitivity is a little lower at that time. That wouldn't be too hard to integrate into the signal as well. And I suppose the final thing following on from fertility then would be to say that I think maybe in my view the best use of these continuous glucose monitors would be related to gestational diabetes. So maybe not relevant to female athletes while they're being athletes, but certainly around that. So gestational diabetes, just as a quick overview, happens in around 14% of pregnancies. And it's when the mother prioritizes the fetus. So because the fetus is growing exclusively on glucose, the mother develops a degree of insulin resistance in order to pass on the sugars to the growing fetus. But that can be excessive and result in poorer outcomes for mother and a larger and poorer outcomes for the child. Now currently, and whenever I present this, I think this is just crazy that this is the way it is. Gestational diabetes, in the UK at least, is checked for after like 28, 29 weeks of pregnancy with either a single blood sample in the morning or a poorly done oral glucose tolerance test. So it's happening, it misses about 50% of cases. It's happening so late that a lot of the excessive growth in the child and negative effects on the mother have occurred during the first 2 trimesters. And then even when you know about it, your options to deal with that by then saying, well, start taking exercise, you're now dealing with a much more heavily pregnant person who may not be able to take that advice or isn't thinking about changing their diet at that point. So for me, the ability to more accurately and early detect this, there are studies already who have used CGMs and similar things to check for gestational diabetes after just 20 weeks, and you get about a 40% reduction in all those negative outcomes for mother and child. And by the way, for the child, that's not just immediately after the birth, but there's even been evidence now that there's epigenetic changes that then could predispose to poor chronic health later in life. So I really think if I had to put my money anywhere, I'd be thinking CGMs would be really useful as soon as you know you're pregnant to start monitoring your blood sugars. And aside from knowing there's any issue, I did start the talk by saying we don't want to worry people, but it could at least make someone think, well, I know what I'm trying to do here. It could be a motivator to encourage trying to keep those sugars a little lower. So the journey we've been on was to define continuous glucose monitors at the top, talk about the accuracy and the situations it may or may not be good for, and then at the bottom to think about the things they can do, the things they can't do, and the things they might do. So I like these Prezi formats because I can talk through a story on one slide, but I always do acknowledge that by the end it's a bit of a mess on the screen. So hopefully you've followed all that. I do like to finish just with a summary of what I think the take-homes would be. For diabetes, these are a blessing. Whether it's type 1, type 2, possibly gestational, I really think there's a lot of potential and value in them. For healthy, or at least non-diabetic people, much less value, possibly only for a person to monitor themselves and compare with themselves yesterday rather than other people or thresholds today. Then for athletes in particular, I think while it might at first seem that there's huge value in real-time signals about fatigue and fueling, I really don't think that we have value in that, and it might even worry the athlete more. And then finally, when we think about female athletes, I think most of the fact that it's not useful for athletes in general applies, although my reasoning that we could integrate with other cycles in the body, the menstrual cycle and the link to gestational diabetes are probably the prime areas where I think women could benefit from continuous glucose monitors. Well, thank you very much for your attention, and thank you for the invitation to be here today. Looking forward to any questions.
Thank you.